Very good morning, everyone. Welcome to Masterclass. Greetings from Indian Society of Gastroenterology. This is the fourth Masterclass uh, in the series of Masterclass on clinical case discussion. Manish, allow more people to enter. There are people are waiting room. Allow everyone to enter right away. Can you allow people to enter directly? All right. So this is a wonderful day today. This is September 5th, which is a Teacher's Day. And we know what role our teachers have played in our lives. Whatever we are is all because of teachers, starting from mother and then to the family and our school teachers, our college teachers, our medical institution teachers. What we are all is all because of our teachers. There's never one teacher. We learn from each other. We learn from our students. We learn from our trainees. So on this occasion, I want to pay my gratitude to all my teachers, starting from my parents and mother and everyone from schools, the colleges, the medical college, and colleagues, and even my trainees. So we want to congratulate all of you on this wonderful day. There are many teachers in the audience. For today's case is on very important issue, that is a abdominal lump and how do you approach abdominal lump, which is the focus of discussion today. And for that, we have two wonderful faculty today, Dr. Amit Mathur and Dr. Saroj Kant Sinha. Dr. Amit Mathur is a senior professor at the National Institute of Medical Sciences in Jaipur. He had been trained at PGI, and then he was in SMS Jaipur, and then subsequently to National Institute of Medical Sciences. We have other faculty, which is Dr. Saroj Kant Sinha. He is very dear to all of us. And incidentally, he had been my batchmate all along. So Dr. Sinha is a professor of gastroenterology at PGI Chandigarh. And again, one of the very humble person and a great teacher. Again, I want to thank Dr. Sinha and Dr. Mathur that you, both of you played a role in my life, that whatever we are, all because of your friendship and your support, and also not only that, but also the kind of time we spent together in PGI. To facilitate today's discussion is Dr. Ansuman Elhens. Dr. Ansuman trained at AIIMS, and later he moved this year itself to SGPJ Lucknow. And again, I want to thank Ansuman that for his teaching to all of us, that he's a wonderful teacher, and the quality he has is remarkable. With this, the gratitude to all the teachers and all the students, I'd like to pass on the baton to Dr. Amit Mathur and Dr. Sinha to conduct this session today, and Dr. Ansuman will facilitate all the proceedings. Dr. Sinha will also introduce two of the participants who are going to discuss the case. Mathur, please.
Very good morning, and first of all, I would thank Dr. Govind, and in fact, congratulate Dr. Govind for such a great platform which we has created, because we all retrospectively realize that how important is the clinical history and physical examination, and to interact with the senior faculty and the DM residents, it's a very good platform. Now, before we go on to the case, I would add on one or two points which we, whenever our DM residents, we tell them is that whenever you start presenting your bedsides, the important thing is to write down all the 15 to 20 topics which are very important for your bedsides. And apart from your book, create all reference, in fact, collect all the reference articles and file them, so that in the next second or third year, you are reasonably thorough reading all those reference articles, especially the Indian literature, which is very important for discussing these bedsides, and which will be very helpful in the future. And you need to document all your bedsides. So these are the things which really pay in the future. Now, I would now hand over the proceedings to Dr. Sinha, who would introduce both the residents who would be presenting such a important topic which we are discussing, that is the lump abdomen. Dr. Sinha, please.
Before I go to that part, I would like to thank Dr. Govind. And this is for us who have spent time in PGI, this is almost a dream initiative. This is a big privilege to be part of such a teaching program on Teachers' Day. And in PGI, we always used to talk that we have presented case to this consultant or that consultant for the rest of the 3 years of our training. And as a resident, we always used to say that, okay, this has been discussed in the bedside. So that used to be the landmark for when we were preparing for exam. And obviously, exam is a preparation to the real life scenario. So we used to dream that we could get to present or listen to the cases which are being discussed at other hospitals, other institutes. So this is a dream initiative by ISG, led by Dr. Govind, that everybody is getting to see such presentations. So with those words, I would like to start with the presentation part. So for that, we have two very bright people from our department here at PGI Chandigarh. The history part is going to be presented by Dr. Arup Chaudhary, and examination part will be presented by Dr. Rinkle Kakadia. So both of them are part of the DM program. They are currently in the third year of the DM program. So in a way, we can say that they are at the threshold of examination. Dr. Arup, please.
And before Dr. Arup starts, please put your questions in chat box. As many doubts we have, and we have the best faculty that they will respond to most questions depending upon the time we have. Please do write your question in the chat box. Arup, you unmute yourself. You're not audible. And start again, right?
Sir, first of all, I would like to thank ISG for giving us the opportunity to present the case in this forum. And at the same time, I would like to take the opportunity to thank all of our teachers in our life to guide and help us in this up to this stage of our life. So coming to the index patient, our patient, who is a 42-year gentleman from Mohali, Punjab, is a grocery shopkeeper by profession and is educated up to class 5. He presented with central abdominal pain from last 4 months with right lower abdominal pain, lump from last 3 months, which was also associated with loss of appetite and a loss of weight. On elaborating history of present illness, his first complaint was abdominal pain, which was onset in 4 months back. It was insidious in onset, and it's central abdominal. It's a crescendo decrescendo type of pain that lasts for 3 to 5 minutes. At the outset, it was 1 to 2 episodes per day. From last 2 months, the frequency have increased up to several times per day. On the intensity on a visual analog scale, he told that it was around 3 to 4 out of 10, and he occasionally need analgesic for the pain. Pain used to aggravated by food intake, usually after 2 to 3 hours. And there was also mild central abdominal distension along with the pain, which was increased from last 3 to 4 times in last 2 months. However, there was no associated vomiting or constipation, obstipation, but patient gave history of a distension and pain, which was relieved after passage of stool or flatus. His second complaint was self-noticed abdominal lump while he touched his abdomen due to pain. It was in the right lower quadrant. At the outset, it was in the size of a cricket ball, but which increased in size over the last 3 months, around 25% of increase in size, which was not painful to touch, and there was no lump elsewhere in the body. And both of these symptoms are associated with loss of appetite, approximately 50% from baseline, and a loss of weight of 8 kg in last 4 months. And on a negative history, there was no history of hematemesis, black stool, bleeding per rectum, or passage of mucus per rectum. There was no history of change in caliber of stool or altered stool color. There was no history of fever, nitrate, cough, or hemoptysis. There was no history of flushing, wheezing, or any shortness of breath. There was no history of oral ulcer, genital ulcer, painful red eye, joint pain, or any skin rash. And there was no history of diarrhea, steatoria, draining sinuses, fistulas, or any perianal stocking or disease. On his relevant past history, he has a symptomatic renal stone disease from last 12 years. For that, he underwent extracorporeal shockwave lithotripsy and disease stenting in 2009. Then again, recurrence of the same symptoms in 2011 and underwent repeat procedure again in 2011. Subsequently, he was asymptomatic from last 10 years. Then he developed acute retention of urine in the month of March 2021. That time he was admitted in a private hospital where Foley's catheterization was done, which was followed by cystoscopy and a stone removal. He is also a diabetic from last 2 years. He was on oral hypoglycemic agent, but there was no history of hypertension, thyroid disorder, coronary artery disease, any history of tuberculosis, or any past history of surgery. On his personal history, he is a non-vegetarian by diet. He used to take non-veg meal 3 to 4 times a week. His bladder habit and bowel habits are regular. There was no history of alcohol intake, no history of smoking or IV drug abuse or opium intake, and there was no history of any high-risk sexual behavior or any tattooing. On his family history, there is no family history of malignancy. There is no family history of tuberculosis. He married to non-consanguinity, and he is having 4 siblings. All of them are in health. And on socioeconomic status, as per modified Kupusami scale, he belonged to an upper lower class of family. This is briefly his treatment history. He is symptomatic since May. That time he had colicky type of abdominal pain, 1 to 2 episodes a day. Then for that, he initially visited a private checkup where he underwent ultrasound abdomen. He was advised to take undergo CT scan. Then in the month of June, he started developing an abdominal lump due to painless, which is slowly progressive. And from this, during this period, he took some alternative medication. As his symptoms are worsening, then he came to PGI in the month of August, where he underwent some investigation.
So here Dr. Arup,
Yes, sir.
I will request you to analyze this patient's symptoms individually. That
Yes.
What is the interpretation of his pain? What is the interpretation for the lump? So that we can ultimately formulate a differential diagnosis. So please explain that how do you interpret his pain symptom?
One
Sorry?
one more point I wanted to add. We also need to specify whether there are any nocturnal episodes because of pain. Because we didn't, were there any nocturnal episodes? Because it helps us in differentiating between an organic and a functional pain.
Yes, sir. He has a nocturnal episode from last 2 months.
Okay.
So his first complaint is abdominal pain, as the character of the pain is crescendo decrescendo type of pain, and that used to be aggravated after taking a meal. And he also gave that along with pain, he has some sort of abdominal distension, and that both of distension and pain used to subside with passage of flatus and a stool. It looks like as a luminal pain is due to luminal origin, probably due to some sort of obstruction, which is not complete. And the radiation, the pain location is around periumbilical. So it might suggest that pain is from a mid-gut bowel loop.
So is it a colicky pain?
Yes, it is a colicky type of pain. It's a crescendo decrescendo type of pain.
And we need to specify whether visceral or what is the type of pain? What do you feel? It's a midline pain.
So most of these visceral pain are usually in a midline, and then parietal pain are used to be in the over the side of the lesion. Okay. So his character is colicky midline pain. I would like to consider some luminal pathology, probably in the midgut origin.
So it is very, for the audience sake, I'm speaking out, that it is very important to judge the type of or the character of the pain. So crescendo decrescendo, to describe a colicky type of pain, their character should be crescendo decrescendo, and the timeline is also important. Within seconds to minutes, it increases and decreases. So ultimately, it is not that it will last for 30 minutes or 60 minutes. It tends to build over a few seconds to few minutes and comes down within few minutes. So that is how this is, because this is temporarily related to contraction, vigorous contraction, secondary proximal to the obstruction in a hollow viscous. So that is very important. And the second part, what Dr. Mathur was talking, is visceral pain or parietal pain. Parietal pain is sharply localized, visceral pain will be always diffuse. So patient will always point out with the whole palm that, okay, pain here. Whereas patients tend to point with finger that, okay, pain here. That is the typical parietal pain. Whereas visceral pain, they will always diffuse, or they will say they don't know exactly where the pain is. So that is the basic difference when we are distinguishing the two types of pain.
Okay. Proceed.
Sir, his second complaint was
No, we have to go one step further, Dr. Arup.
yes, sir.
Because we are talking of GIT, so we have to make a conjectural guess that this is from which part of the GIT. So does pain explain us that what is the level of origin of pain? Whether this is stomach, gastroduodenal area, jejunal area, ileal area, colonic area, rectal area. So can we have some idea on the description of pain?
Yes, sir. So in case of foregut pain, which is basically in the epigastric region, and in case of midgut origin pain, which mainly implies part of most of the small intestine and some proximal part of large bowel, that pain usually in the periumbilical or central in location. And for a hindgut pain, that is because of probably it is a hypogastric in location.
So roughly hindgut pain can go either in the left iliac fossa, hypogastrium, or at some places it is mentioned that if you draw a line from left hypochondrium to right iliac fossa towards the left side of it, the hypogastrium pain will go. This we are talking strictly about the visceral type of pain. This we are not talking about the parietal pain. Parietal pain is because localized pain, so anything happening locally will mark to that area. So visceral pain, epigastric pain, visceral, that will be foregut. Around umbilicus or central abdominal pain, that will be midgut, and either hypogastrium, left iliac fossa pain. Rarely it can go to left hypochondrium. That is the hindgut origin of pain. So here that gives a fair idea that what is the site of involvement, site of the pathology.
Yes, sir. Sir, should I go with the second symptom, sir?
Yeah.
So his second symptoms which developed after the onset of pain, it is a lump in the right lower abdomen, and which is, he told it is painful to touch, non-painful to touch. So, sir, a lump in right lower abdomen, we'll have to consider this with either bowel origin or a non-bowel. Whereas the patient has the most common lump in that particular area is either from this appendical, cecal, terminal ileum, or the vascular at that particular area, or rarely, sir, peritoneum or retroperitoneal structure.
And also ascending colon.
Yes, sir.
Also the lymph nodes.
And lymph nodes, sir.
Okay.
So in our patient, we had a lump along with a preceding history of involvement of bowel. So I will consider such this lump could be either distal part of ileum, originate from the distal part of ileum, or the proximal part of ascending colon or cecum, sir. Otherwise, this luminal symptoms from this non-luminal sexual lump is very unlikely, sir, to present with.
Okay. So that means we are dealing with a pathology in the distal part of ileum or ascending colon, or that is the right.
Cecum or ascending colon, sir.
So go ahead.
Would you like to summarize your findings?
Yeah, let's have the summary of the.
So here we have a 43-year-old male with a background history of treated renal stone disease and a diabetes. He presented with progressive colicky abdominal pain with abdominal distension without vomiting and constipation from 4 months, and with an awareness of non-painful progressive lump in the right lower abdomen from last 3 months. Both of these symptoms are associated with loss of weight and a loss of appetite without any history of B symptoms, fever, diarrhea, perianal pain, discharge, or any GI, gastrointestinal bleed.
Here, I would like to add on to this thing. You started with progressive. I think it could be recurrent episodes of colicky abdominal pain rather than the progressive word which you have used. And the second is, whenever you talk about the summary of the symptoms, it has to be in the words of what the patient has described you. So adding on without the history of B symptoms, I think it is better whatever the patient positive or negative history he has given, we summarize that, because on the basis of that we are going to make a diagnosis. So without so we can avoid without history of B symptoms in the summary. One is recurrent episodes of colicky pain, and maybe avoiding what the patient has told you. That should be in this.
So what Professor Mathur is saying is very, very important, that in the scientific forum, it is very important to be precise in description, and the message should go very clear to the listener what you want to say. So progressive is obviously clearly here is inappropriate word here. So the listener will interpret it differently. So whenever we try to say or go in the scientific forum, we should carefully look at every word of it, and then accordingly we should refine it as far as possible. So there is there is no confusion in communication. So everybody should be saying the same and understanding the same. It is not one person wants to say something and the listener is trying is understand something different. Okay, proceed, Dr. Arun.
So before we'll have an opinion of, we take an opinion of the participants about the diagnosis. Let us keep an audience poll to see what is the audience opinion of the diagnosis. So we'll have an audience poll here. Yogita ji, can you turn the poll on so that the audience can vote? So let's see what the audience polls. So you can start polling. These are the 4 differentials. What is your top differential? You have to choose. First, A, ileocecal TB. B, a colon cancer arising from the ascending colon or asthecum. C, an appendicular lump. D, ileocecal lymphoma. And others who, since we have only 4 voting options, you can choose and mention in the chat box if you like.
So we have very good attendance here. Almost 185 people, 200 people attending such type of academic forum, which speaks of itself.
So I think we'll share the poll results in a while. I think the results as they accumulate look very interesting. So more and more people are waiting. We'll just take a couple of seconds and we'll share the results. So we have the results here. So almost 60% of the participants have chosen option A, ileocecal TB, as their top differential. And 20% have chosen colon cancer, around 10% ileocecal lymphoma, 6% as appendiceal lump. So almost majority of the audience is on basis of history is in favor of ileocecal TB, and 20% feel that it is CA colon, and 10% feel it is ileocecal lymphoma, and 6% feel it's an appendiceal lump. So there is no definite answer to it at this point. So the things will unroll as we go through the case.
We have a very interesting question coming from the audience. I know we have answered to this question subsequently, but Arup can try to answer, or somebody can take answer. The question is, can we keep GIST in the differential diagnosis at this stage?
I think this would be discussed subsequently.
There is answer in subsequent presentation, but Arup, will you like to respond? Short, very brief.
So I kept the possibility of GIST at this situation, but however, there are some odd points regarding GIST, and that GIST with such a big GIST and without a GI bleed, I will keep it in a lower down possibility, sir, not in a higher up possibility.
Okay.
So we have a closely related question. So which of the following is the most common cause of a right lower quadrant lump in our country? So it's, I think, closely related to this only. So Yogita ji, can we run the polls again? So all of you can vote. The options are A, an appendiceal lump, B, an ileocecal TB, C, carcinoma colon, and D, lymphoma. So let's see what the audience have to say. So the results are accumulating. We'll share with you in a couple of seconds. So almost 60% again say it is ileocecal TB. But this time the proportion in favor of appendiceal lump have gone up. 40% are saying it's an appendiceal lump, which is the more common. And CA colon and lymphoma doesn't have much takers, less than 5% each. So almost 60 and 40 is the difference. So let's see what is the answer to this. So appendiceal lump is in fact the most common cause of right lower lump in our country. I think there can be controversy regarding this. Some people would like to argue that it is an ileocecal, but I have taken this reference from S. Das Manual of Clinical Surgery. And to my support, I have a number of case series from different state medical colleges, also from Nellore, from Bharatiya Vidyapeeth, and in which number of dissertations done in this. They described the spectrum of right iliac fossa mass, and almost 50% of the right iliac fossa mass are appendicular lumps. And the next is definitely ileocecal TB, but appendicular mass tops the list.
I think this is happening because of the selection bias for the audience, because this audience is dominantly gastroenterologist, medical gastroenterologist audience. They tend to see fewer appendicular conditions, which are dominantly seen by the surgeons. So if there is combined audience, possibly the results will vary. So that has possibly played. So the actual answer goes against the public opinion of this meeting. So, but the fact remains that appendicular lump is the commonest type of lump in the right area.
In our day-to-day practice, also we feel appendicular lump is the most common. This thing.
So let's see what the participants have made the differential. So, Dr. Arup, please take over.
So to diagnose from the historically, we have a patient who is having recurrent intestinal colic with partial symptoms of partial bowel obstruction with a right lower quadrant lump, likely to be level at distal small intestine or right colon. I would like to consider both possibilities, but still I will consider malignant etiology first over ileocecal tuberculosis.
Just one point, Anshuman, and can you close this the poll? I mean, we are getting that poll on the screen.
Okay, sir. The diagnosis screen is visible. I'll just stop sharing and share again.
The question 2 is on the screen.
Oh, okay, sir. I'll just change it. So the diagnosis slide is visible, I hope, sir.
Yeah.
Yes.
I don't know.
So Dr. Arup, you can go ahead, please.
Yeah.
Sir, as of in our patient, we have a patient who is 42 years of male who is having recurrent intestinal colic with symptom of partial bowel obstruction with right lower quadrant lump. Likely level of obstruction would be a distal small intestine or a right colonic. And I would like to consider both the etiologies, but I will prefer, sir, I will consider malignant etiology over, sir, ileocecal tuberculosis.
Okay.
You will have to justify why you are considering malignant over benign over TB.
One thing, Arup, I just wanted to ask you: do we need to keep recurrent intestinal colic with partial intestinal obstruction, or just recurrent partial intestinal obstruction as a diagnosis? Do you need to keep intestinal colic as a part of your diagnosis? Because usually this partial obstruction we are having, and this is presented as an intestinal colic. So as a diagnosis, would you like to keep a recurrent partial intestinal obstruction with a right lower quadrant lump?
So I would prefer the recurrent partial bowel obstruction, because partial bowel obstruction are usually recurrent.
Yeah. I mean,
so this could have been recurrent intestinal colic due to, rather than with, it could be due to partial
or recurrent
small
partial
bowel obstruction.
Yes.
Okay. Okay, go ahead. Just a small.
So I prefer some malignant over ileocecal tuberculosis because the patient, in our index patient, he had a lump which is progressive. This is progressive in size, is increased 25% size in last 3 months. And secondly, we don't have a symptoms like fever or night sweat in our index patient. And almost 1/3 of patients of tuberculosis have other evidence of involvement of tuberculosis in either, say, mainly the pulmonary tuberculosis. And one important feature is the tubercular lump, the patient usually does not complain about the lump. It is the physician who finds the lump and patient then follows. But in our index patient, the patient himself finds the lump and he told that it was 25% increase in size. So all these points, I would like to consider malignant as a first etiology, then tuberculosis is the second possibility.
No, do you feel that intestinal tuberculosis, they don't present with lump? What about
So, intestinal tuberculosis patient can present with lump, but that lump is usually a ill-defined lump. Most of the time, patient cannot appreciate that.
This is on the basis of history which we are talking about.
On the history of history, sir, this is basically a small, usually a small lump. The patient doesn't complain about the lump normally, sir. It was the physician who told him that there was a lump, and then patient subsequently followed up. And there was no progression in size of lump in a short span of time.
There is an interesting audience question coming up. Can we diagnose as subacute intestinal obstruction? So audience wants to know about the use of the term subacute intestinal obstruction.
So this terminology, the subacute or the acute intestinal obstruction have been, there is no terminology called subacute intestinal obstruction. Either it's a complete bowel obstruction or a partial bowel obstruction. And most of this importance of acute bowel obstruction is the risk of ischemia. So there is, at this moment, there is no terminology that explains subacute bowel obstruction.
Right. What?
Because Sinha, can I add one word here?
Yeah.
So I think you raised a very important point. The term, only we in our country use the subacute intestinal obstruction. Acute, subacute, and chronic are the feature of timelines. Acute liver failure, chronic liver failure, subacute liver failure. We're talking in terms of timelines: 4 weeks, 8 weeks, 6 months. But in intestinal obstruction, we're talking in terms of severity. Is a complete obstruction or partial obstruction? So therefore, although we mean, if you say subacute, we mean it's a partial intestinal obstruction, but better we don't use this term, because if you publish a paper on using subacute, they will never be cited once somebody looks at partial intestinal obstruction, and your paper will never be quoted that way. So I think all of us should stop using the term subacute intestinal obstruction. The better term is partial intestinal obstruction. And there are 3 types. We have a stage of intestinal colic when the obstruction is not too advanced. Then we have a phase of intestinal colic. Then we have a phase of partial obstruction, then complete obstruction, and complete complicated. And also remember that in all of our patients which we see in gastroenterology are mostly chronic disorders. They're not acute. They're not intussusception or valvulus. They'll come to surgical emergency. I know why they go to surgical emergency, but they come. Somebody has acute pain of valvulus or intussusception or hernia, getting strangulated. They all go to surgical casualties. They don't come to medical emergency generally. Most of the patients who come to us will be chronic disorders like tuberculosis, Crohn's disease, ischemic strictures, or drug-induced strictures. All those will come as a chronic disorders. So please do remember that we should not use the term subacute intestinal obstruction. Better term is partial obstruction.
So I do agree with Govind. Actually, we need to now redefine it's a partial or a complete obstruction. And then with the history, depending upon the pain, the presence of abdominal distension and vomiting, we need to localize the site of obstruction, whether it's a proximal small bowel obstruction or a distal small bowel obstruction or a colonic obstruction. So that is how we teach the residents: partial, complete, and if possible to localize the site of obstruction based on the 3 major complaints of the site of pain, the presence of vomiting, and abdominal distension. So that's a better way rather than defining subacute obstruction.
I think we can move on to interest of time.
Yeah. Dr. Arup, can you talk about the rest of the differential diagnosis? Ileocecal lymphoma, GIST, gastrointestinal stromal tumor, and neuroendocrine tumor. Are they serious contenders?
Sir, I will keep lymphoma as a third possibility after tuberculosis. And lymphoma in the age group of 4 to 5 decades may present with abdominal pain, obstruction, and a lump. However, that point against lymphoma is that this 1/3 of patients of lymphoma usually have fever, evening rise of temperature, or night sweat and malaise. And this symptom complex is not present in our index patient. So regarding, sir,
and also because lymphoma is a much less common tumor compared to colonic carcinoma.
Yes, sir. Again, the GIST is a rare tumor, and usual site is in the small intestine. Usual site is the jejunum. So annual GIST is unlikely, but this can present with pain, but presenting with symptoms of obstruction is very odd against diagnosis of GIST. And this normally present with bleed, GI bleed. So absence of GI bleed also rule out the possibility of this GIST in our index patient.
And also
And
the rapid progression of the symptoms, and also the lump. You hardly
Yes,
have
sir.
a lump in patients of GIST. So that also you
yes,
need.
sir. And finally, sir, neuroendocrine tumor, actually they are as a palpable lump in the right iliac fossa is very unlikely, sir. And then again, this patient have the growth kinetic is a slow growing tumor. So the rapid progression of size in the 3 months is against the point of neuroendocrine tumor. However, the location is maybe the possibility that at the right iliac fossa we have a ileal knit, but this points against that is the palpable lumps, growth kinetic, and this goes against the diagnosis of knit in our patients, sir.
Some interesting questions coming from the audience. That in view of history of renal stone disease, should we considering Crohn's disease as a strong possibility? Interesting question, I will say. Arup can try to answer it, but before that, I will like to say possibly the people are giving too much credence of increasing incidence and prevalence of Crohn's disease in India over last few years. So if we talk about 10 years back, nobody would have even talked of Crohn's in this patient, but it is interesting to see that people are talking as a first differential diagnosis as Crohn's in this situation. Arup, will you like to answer?
And also in the differential of tuberculosis, we are always keeping Crohn's. So obviously that's a good question. You need to take it.
Sir, in patient with Crohn's, if they have a lump, it is either a complicated disease procedure. So, and that patient, this is basically abscess. So patient usually have a symptoms of fever, toxemia. And secondly, patient also have a symptoms of bowel disease like diarrhea. These are most important common presenting symptoms and directly presenting with a lump. So preceding history of diarrhea, then will suggest a case of Crohn's if patient have other symptoms of toxemia like fever or pain, tenderness, that suggests the diagnosis of Crohn's. But in this patient is very unlikely to have a Crohn's with complicated Crohn's and as a first line of diagnosis.
You need to add such a significant anorexia and weight loss in Crohn's would be unusual.
Unusual, sir.
Can I add, Master, can I add one point out here? As a part of learning, so once you feel a lump abdomen, it means more cells, more positive signs, more inflammation or more cells. See, in the Crohn's disease is more of a negative sign that you have a loss of tissue, ulcerations. So lump formation in Crohn's will be unusual unless it gets complicated, as Dr. Arup said, that if there is a local abscess. So the abscess means more tissue, more pus, more inflammation, they form a lump. So with lump abdomen, in general, your diagnosis towards mitosis becomes the first preference, because you're talking of positive tissue accumulation. The cells are dividing and they're making a mass-like lesion. That do happen in other situations like tuberculosis, do have a mass, but less common compared to malignancy. And also, like, for example, in this situation, we would like to consider the possibilities of amoeboma or other unusual things. One need to keep those in mind. they can have a different clinical picture. And second point would be that a short history of few months pain abdomen, few months lump, it means it's more of a positive tissue accumulation, more of a rapidly growing lesion. And therefore, mitosis becomes a spontaneously first choice. It will vary from patient to patient, but keep these points in mind while you make your differentials order-wise, which is more important, which is less important.
One very interesting question coming up from the audience. We have indirect answer to this, but this is slightly different than what we have in the subsequent presentation. The question is about the lump in tuberculosis. The patient felt by the patient versus detected during examination. The Dr. Piyush wants to know, is there any data to show that what is the difference and what are the numbers?
So there is a paper from Tamil Nadu, the Indian data, State Medical College, that they find this lump case series of 50 patients of lump in right iliac fossa. They have reported that ileocecal lump are basically most of the time it's found by the physician, then patient find that there is a lump. In contrast to this malignant lump, which are well defined and find by the patient himself.
So that is all right, but I am not aware of any paper which talked of the lump detected by the patient versus lump detected by the physician. So if Dr. Mathur is aware of any paper.
Dr. Sinha, I think we need to go. We have only
we'll go to examination now. Okay. Dr. Rinkel can take over.
Thank you, sir. So I'll be going with the examination. Examination was done after examination and photography both were done after consent. So on general physical examination, vitals were normal. Patient is having BMI of 22.3 kilogram per meter square of body surface area. On general physical examination, there was a pallor. There was no icterus, cyanosis, clubbing, a generalized lymphadenopathy. Or a pedal edema.
Wrinkle, 1 second. Yogita, please ask Manish to mute all the participants. And can you listen?
I would request Manish ji to please mute all the participants apart from the organizers.
Please carry on.
Okay, so on the general physical examination, vitals were normal. The patient is having BMI of 22.3 kg per meter square of body surface area. On rest of the finding, there was a pallor. However, there was no icterus, cyanosis, clubbing, lymphadenopathy, or a pedal edema. So on other general physical examination, oral cavity was normal. A skin and nail was also normal. There was a Ryle's tube in situ with RT aspiration. So on abdomen examination, on inspection, the shape of the abdomen was scaphoid with central and inwardly placed umbilicus. There was a smooth bulge with normal overlying skin was noted in the right iliac fossa, hypogastrium, and involving the part of umbilical area. However, there was no scar, dilated vein, visible pulsation, or peristalsis anywhere in the abdominal examination, and the hernial sites were empty. On the palpation, there was a lump of a 10 into 8 centimeter size approximately located in the umbilical area, hypogastrium, as well as right iliac fossa with normal overlying skin. It was not tender on the palpation, hard in consistency with irregular, well-defined margin with nodular surface. It does not move with respiration. It has no mobility on side to side also. And it become less prominent on the leg raising test. So on percussion, there was a dull note over the entire lump. There was no shifting dullness. There was increased vowel sounds on auscultation. There was no bruit on the lump On digital rectal examination, external examination was normal. There was no palpable mass on the per rectal examination. The tone was also normal. Finger was stained with yellow stool. Proctoscopy was also normal. The rest of the systemic examination were also normal, including respiratory, cardiovascular system, and central nervous system.
Before we take the opinion after examination of the participants, let us ask the audience now, what is their top differential after examination? Has it changed from the one after history? So Yogita ji, can we please run the polls? So all of you can participate. The differentials are same. A is ileocecal TB, B is colon cancer of the cecum or ascending colon, C is appendicular lump, D ileocecal lymphoma, and others can definitely mention in the chat box. So Yogita ji, can we have the poll results? So we'll be ready with the poll results in a couple of seconds as the participants are voting. So it's very interesting to see the changing trend, which we'll shortly share. So in fact, we do have the results now. Almost 60% now feel that it is in fact a colon cancer of cecum or ascending colon. Whereas after history, majority felt it was an ileocecal TB and only 20% had felt it is colon cancer. And the proportions have reversed. Earlier, 20% were feeling it was an ileocecal TB on history. 60% were feeling it was ileocecal TB on history. Now the proportion has come down to just 20%. And there aren't much takers for appendiceal lump, ileocecal lymphoma, or other DDs. So very interesting to see how after the examination, there is a switch between ileocecal TB and CA colon. So we'll come to the exact diagnosis as the results unfold. Let us see what the the discussants have to say of the diagnosis.
Before we go to that, there is an interesting question coming from audience. Dr. Jayanti wants to know intrinsic mobility and plane of mass. So plane of mass we are going to discuss, so that wrinkle you can take later on. But she wants to know about intrinsic mobility of the lamp and also about the local gurgle, because as you understand that many physicians, they in case of bowel obstruction, they are always interested in gurgle. This can be of different types. One can be because of gurgling sound because of the increased bowel motility, and the second is cecal gurgle, which is generally appreciable in case of obstruction beyond cecum, ascending colon, transverse colon, anywhere, then you can find cecal gurgle. So was there any cecal gurgle that, and you can comment on the intrinsic mobility of this mass region?
Sir, there was no gurgling sound around the local area surrounding the mass or in the mass per se, and there was no mobility also, it was fixed.
Okay, good. So now you can proceed further.
Okay. Sir, so diagnosis would be a recurrent intestinal colic due to a partial bowel obstruction with a right lower quadrant hard nodular lump involving right iliac fossa, hypogastrium, and part of the umbilical area. So my first differential diagnosis would be a colon carcinoma, as we are suspecting it is a luminal pathology arising from the ileocecal region, and it is a malignant. So the colon cancer would be the first differential diagnosis which I have kept. Though the age is little bit younger, but in India, 10 to 20% cases has been reported prior to age of 40. So the colon cancer in this area, I would keep my first differential diagnosis.
Can I add one thing here? Usually when you diagnose a lump, we would like you to define whether it's an intraperitoneal or a retroperitoneal lump, and what are the constituents of the lump which you feel after the palpation. So this is very important actually, whenever you are making a diagnosis.
Sir, on examination, it seems to be a retroperitoneal because it has no mobility. It is almost seems to be fixed, and it was less prominent on the leg rising test. The another test we can perform knee elbow position, whether it is falling forward or not. If it is falling forward, it seems to be intra-abdominal. If it is not falling forward, it will be a retroperitoneal. But in our case, our patient was not able to get in knee elbow position, so we didn't perform the test.
So it's a retroperitoneal. And what do you feel are the constituents of the lump, which after palpation?
It is the entire lump was a hard nodular lump. I don't feel any varying consistency in the lump.
Yeah, but
And the margin was very well defined.
intestine, the lymph nodes, and possibly the mesentery, which is forming the constituents of the lump.
Mesentery and maybe omentum also.
Momentum.
Omentum. But it is very important to remember that primarily the lump may arise from an intraperitoneal organ or may arise from retroperitoneal organ. But in large lumps, when the characteristic can be overlapping. When intra-abdominal origin can get fixed from the retroperitoneal, it will show some of the properties of retroperitoneal lump. And similarly, retroperitoneal, if it becomes large, has a dominant intra-abdominal component, some of the features of intra-abdominal. So overlap features are not unheard of or not very, very rare. So that can happen. So that also should be kept in mind. One very, very interesting question raised by interesting, and I will say very, very important. Once we burnt on finger on this issue, coming from the audience, that was testicle examined. It is very, very important to examine the testicle in male patient. You have, particularly if you have lump of retroperitoneal natures. Once in last 20 years, I remember that we burnt our fingers. We kept on investigating the patient for almost 6-7 days. And after that, we detected that the patient actually had testicular mass lesion, and the lump which we are palpating were actually metastasis from testicular tumor. So this is described in literature. This is mentioned in the textbook. So in every patient who presents with the features of retroperitoneal lump, in male patient, testicles should always be examined. So this is coming from one of the audience. So was testicle examined in this patient, Dr. Rinkel?
Yes, sir. The external genitalia was examined. The bilateral testis was descended and it was in the scrotum only. And they were not enlarged.
Okay. Okay. We'll move ahead.
So now before we move, one answer, Dr. Rinkel, that
Yes, sir.
Why we have excluded TB now at this stage after examination, based on what findings? Because history we had everything, and then we are removing some possibility based on the examination finding. We should be on solid ground that on that ground we excluded the ileocecal TB.
Sir, the characteristic of a lump was not fitting in with the ileocecal lump. Ileocecal lump are usually tender on a palpation. Along with it has a varying consistency because the lump is usually formed by a metriate thickened bowel loop along with mesentery or a lymph node. And they are used to be a ill-defined, most of the time they used to be a ill-defined vague lump rather than a clear-cut, well-defined hard lump. That's why I feel it is.
Can you give the breakup of what is the location of lump in case of intestinal tuberculosis?
Sir, the location of a lump in it would be little bit higher because of the pulled up cecum and ileocecal region about in the subhepatic region. So the location of the lump would be little bit higher rather than it is fixed to right iliac fossa and hypogastrium.
So this is very interesting. This is for the audience that the ileocecal lump, the most common site is not actually the right iliac fossa. It will be in the right lumbar region. It can go even in the umbilical area. Less frequently, it can be the right iliac fossa. So literature wise, there are percentages mentioned for each region in large series. So that is very, very important. Another point we distinguish is in older literature. In last few years, this point has not been highlighted in most of the papers. But in the older literature, that if you have very large lump, cutoff mentioned is in different papers, different 5 centimeter, 6 centimeter, and 8 centimeter. Our patient has 10 centimeter lump. So this is clearly by that criteria, this is a large lump. So beyond that, most of the tubercular lump are less than 6 centimeter or less than 8 centimeter lump. So that also, this point also goes in favor of malignant lump rather than lump of tuberculosis. Although rarely we all have seen very, very large size lump due to massive lymph node enlargement in TB.
Can I make a couple of points out here? The point number one, that the age of diagnosis. See that the age is not a very important criteria, although we teach every time that you consider age or gender in your differential diagnosis. But you know that medicine is now every disease spectrum, and almost all diseases do occur in multiple ages. We are at the top level of gastroenterology. We are not at primary or secondary care. So you don't want to know only the top bars of, say, the most common age is 30 to 40 years or 30 to 70, 40 years or 50 years. You look at whole spectrum. So some patient will be younger, some patient will be even older. Even inflammatory disease can occur at 70 years of age. You have diagnosed Crohn's at the first time at 70 years of age. But again, you diagnose not because of age, you diagnose because of clinical symptomatology, the behavior, the natural history of the disease. So do consider age, but again, don't give too much importance on age or gender. I think we overemphasize age or gender while making a diagnosis, because the most important here is a lump abdomen. Lump you palpated is a firm lump or a hard lump. So it only tells you why it is hard and why it is soft. Hard only because in the small space where the lump is arising, there's a compactness of cell. The cells are very compact with each other because of multiplication. Once they multiply, the available space becomes very hard, because in the same space, there are millions of cells. That's why it becomes hard, right? For example, you remember you take a sand bag. In a sand bag, you put more sand and fill it completely by putting pressure on that. You find it becomes hard. But in the same sand bag, you take out a couple of kgs of sand out of it, it becomes soft or it becomes firm. You take out further more kgs from the sand bag, more sand, it becomes soft. So all about compactness of cells in that particular location or particular region, which tells you. So when you find a hardest lump, no doubt, or firmest lump, you're thinking in terms of more towards mitosis or inflammatory. Second thing, what I want to say that rapidity of enlargement, which I said earlier, is also very important. That acute, so some lump which occurs within days, it can't be mitosis. It is mostly inflammatory, because inflammatory things, the doubling time is much faster in the inflammatory lesions. But and in mitosis, they will be still rapid, but not as rapid as the inflammatory. So they keep a couple of these things in mind while you interpret the lump and its natural history.
Interesting question coming from very, very senior gastroenterologist, Dr. A.C. Anand. He is asking, tuberculosis is known to cause painless lump due to lymphatic tuberculosis and by causing psoas abscess or the cold abscess. Dinkle, will you like to respond to it?
So the psoas muscle abscess patient would have a back pain along with some restricted mobility of lower limb as well as pain in the groin area. Here it is not the case, and that is also. But
and also this patient has a recurrent, recurrent partial small bowel obstruction or midgut obstruction. So that will be extreme rarity with psoas abscess. Okay, so that settles the issue.
Siddha, one more question comes. Like, if you permit, I can take this question.
Yes.
The Bilal Ahmed Mir has asked this question. That if I read, to explain diagnosis by a common presentation of a common illness, then by uncommon presentation of a common disease, then by, so this is a teaching from third year medical student, that try and explain everything by a common disease. Common disease occurs commonly. That's good at primary care center. That's good at secondary care center. But we are a specialist. We work at tertiary care centers. Each one of you is working at tertiary care center. And even if you're live later, you'll work at a tertiary care center. You won't work in a primary care center, primary care type of physician. So if this phrase does not apply to us, earlier to stop this phrase, better for us. Certainly common disease occurs commonly, but they're treated at common places. Only then they come to tertiary care centers. So this principle does not apply to us, or apply to not only to any specialist, because people go to a specialist for a specific issue. They don't go for simple pain abdomen or a simple constipation. They come to you after years of prescription by multiple physicians. Then they reach you. So please keep in this mind, and therefore you are likely to see uncommon disease. Even this one uncommon disease in your population, in your locality, they'll come and see you. A rare disease, the person, where did they go? They come to you. So we need to be open our mind that if the natural history, if the clinical history suggests it to be rare disease, it's fine. I'm willing to accept as my first diagnosis, even at the risk of being wrong. But rare disease, unless you think, they require specific investigation, they require special care. And unless your mind is open towards that, we are going to miss that, and we are not going to investigate for that. So please do keep in mind that we are specialists, and this phrase will not always apply to us.
So can we move ahead now?
So since we have just finished with the examination, it's good to brush up our knowledge. We have a poll for the audience. Which of the following is the best describes the transpyloric plane? It lies midway between the sternal angle and the umbilicus. It lies midway between the sternal notch and pubic symphysis, midway between the sternal angle and pubic symphysis, or just below the costal margin. Yogita ji, can we please run the polls? So let's see.
Poll, please. Yogita?
So we have started the transpyloric plane. The participants are voting. The results are accumulating. We'll share the results in a couple of seconds with you. So very interesting to see the results.
Looks like mixed verdict.
So let's share the answers. Only 20% of the people have got it correct this time. The majority of people have chosen just below subcostal margin. In fact, that is the subcostal plane, and midway between the sternal angle and umbilicus, 30% have chosen. The correct answer is it lies midway between the suprasternal notch and the pubic symphysis. This is the transpyloric plane, and it lies at the L1 level. Another way it has been described is you can find it lying midway between the xiphy sternum and the umbilicus. Another way to locate it. Either you can locate it by midway between the suprasternal notch and pubic symphysis, or midway between the xiphy sternum. And this time only 20% could get it correct. So let's proceed with another audience question for the audience so that they can brush up with their knowledge of physical abdominal examination. Which of the following is not used to divide the abdomen into the 9 regions? Transpyloric plane, mid-clavicular plane, mid-inguinal plane, or transtubercular plane? So audience, you can start voting on this one too. It's not a good idea to brush up your knowledge of physical examination. So can we run the polls now? Which of the following is not used to divide the abdomen into 9 regions? So Yogita ji, can you share the poll screen? So I think the poll has started. We'll share the results in a while. So the results again very surprising. I think all of us need to brush our knowledge again. Only 5% people have got it correct this time. So we'll come to it later, but the correct answer is transpyloric plane. It is actually the subcostal plane which is used, and my reference to this is Hutchinson's clinical method, the latest edition. So we don't use transpyloric plane. In fact, the upper horizontal plane is the subcostal plane, the lower horizontal plane is the transtubercular plane, and the 2 vertical planes are the ones which pass between the mid clavicular point above and the mid inguinal point below. So in fact, it's the transpyloric plane. The transpyloric plane lies a bit higher up at L1 level. In fact, and the subcostal plane starts at L3. So surgeons might have a different opinion, because I think the S. Das manual of surgery mentions a bit differently, differs from here. But for the gastroenterologist, I think the Hutchinson's clinical method is the gospel. So, and they should follow this.
So this was very, very important, because a accurate description of lump and site of pain and other things we need to be aware of. And because nobody tends to revise these things after MBBS days, so it was good to revise here. So we can proceed here.
So we just have another poll question. Another interesting, which of the following retroperitoneal mass moves with respiration? So the traditional teaching is that retroperitoneal masses don't move with respiration. So which of the following retroperitoneal masses move with respiration? Let's see. So the poll is running. We'll share the results. Again, very interesting.
What is AAA, Ansuman?
Sir, abdominal aortic aneurysm.
Okay.
So let's see the results. So I think the audience this time, again, the opinion is divided, and around a quarter of the audience have got this correct. So the answer to this is the pancreas. I think there was a very interesting study from PGI Chandigarh, and almost all of us must have observed this, that during ESWL of pancreatic stones, we must accompany, and urologists and us have a very difficult time focusing on the stone. All of us have noticed, but the conventional teaching says that pancreas does not move. So from PGI Chandigarh, Professor Bhasin did a very interesting study, and during fluoroscopy observation, they saw that the pancreatic stones in fact do move with respiration. And in their series of around 25 patients, they have shown that you can see here the pancreatic calcification at the end expiration lying at L1 level moves down almost around 3.5 centimeters to the maximum to the lower vertebra. So I think this was a very interesting study and goes against the traditional teaching that pancreatic masses are filled.
This we remember very clearly, that I did my DM during 96, 99. So during 98, 99, we were recording these cases, and some of the cases I had actually recorded during fluoroscopy inspiration and expiration. But subsequently this paper was published little late. So that's why it is listed 2006, but the work we started actually in 1998. And that time we were documenting in inspiration and expiration field. So pancreas moves with respiration, and that is a very significant, very significant movement, and that has important implication for ESWL.
So I think since the participants have removed ileocecal TB from their list of differential diagnosis, I would just like to ask shortly, what fraction of patients with intestinal TB can present without fever? We'll take this very quickly and share the results with you as the results are accumulating. So we have the results now. Almost 50% say that 20 to 40% of the patients can present without, but the correct answer is in fact 40 to 60%. So I've taken this table from the beautiful review article by Dr. Rathi from published in JAPI, and the case series in India say it's around 40 to 60% do have fever, and again on the contrary 40 to 60% can present without fever. So this is very important thing to know. And just based on the absence of fever in case of right iliac fossa mass, we should never rule out the tuberculosis as a diagnosis.
Just for clarity of audience, I would like to mention here clearly, the figures vary for intestinal tuberculosis and abdominal tuberculosis, because abdominal tuberculosis will also include the ascitic form and pure lymph nodal form of tuberculosis. So there the figures tend to get a little higher in some of the series, reaching up to 100% also. So that is difference. But this figure is mainly for intestinal TB. So this is acceptable. So audience should be aware of this.
Sir, I think we can go ahead with the investigations if you permit.
Yeah. So we would ask them how do you plan the investigations? What do you
So for DM residents, I will for the clarity sake, I will like to mention that at this stage, then generally there are two types of question. How will you proceed with investigation? So then you proceed in a stepwise manner, taking care of the confirming the diagnosis, looking for the complication associated and the points which have significant bearing on the immediate management of the patient. So accordingly, you will ask for investigation. And the second type of question examiner tend to ask is how will you confirm the diagnosis? In that scenario, you go straight to the relevant investigation, which will confirm the diagnosis, not bothering for other associated conditions, stratification, trials, and other things. So Dr. Mathur, I don't know what he has in mind.
I think since we are running short of time, we need to go on to the
confirm the diagnosis.
Yeah.
Okay. So Rinkel.
Sir, to confirm the diagnosis, first I would like to have a CECT abdomen.
So we'll share the CT abdomen with you. So this is the CT abdomen. You can just read out the films. I can scroll and point out wherever you are saying. So Dr. Rinkel, please go ahead.
This is a CECT abdomen in a venous phase with axial sections. We can see here it is a bilateral hydroureteronephrosis. Along with this, there are prominent gas-filled large colon loop with a normal small bowel loop.
So I'll scroll down the slides further.
Sir, on the further slide, we can see there is some mural enhancement and some thickening in the descending colon on the left side.
So I think they have given rectal contrast. Probably that's why it's appearing
yes,
like.
Yes, sir.
So here are the still scrolling down.
So in this section, we can see here there is a lump which is enhancing, almost causing a luminal narrowing of a terminal small bowel with luminal narrowing, and then the limb is heterogeneously enhancing in the next section with some necrosis within it, with an extensive mesenteric fat stranding. Along with there is some thickening in the right-sided colon also in the ascending part of the cecum.
And here are the still more some films from.
So on the lower cuts, the higher size of the mass, along with we can see the lost flat plane with the psoas muscle. Along with there is a symmetrical thickening of a sigmoid colon. However, the rectal contrast was passing beyond it.
So let's see what the radiologist.
What other important, you would like to comment on the lymph nodes or the vascular invasion also? Is it possible? Is there any involvement of the lymph nodes which we can?
I could not appreciate any separate lymph nodes, sir.
And even the vessels, I think you're not able to really.
So let's see what the radiologist reported for us. So there was asymmetrical polypoidal thickening in the terminal ileum here with the maximum thickness of 2.5 centimeter, mild luminal narrowing and no proximal bowel dilatation. There was a 4 into 4.6 into 3.8 centimeter heterogeneously enhancing infiltrating mass in the mesentery, which was infiltrating the sigmoid colon with extensive fat stranding. There was mural thickening in the sigmoid colon with luminal narrowing, but the contrast was able to pass beyond it into the descending colon. There were multiple surrounding lymph nodes. Largest was 1.6 centimeter. And there was some mild hydroureteronephrosis as well.
Okay. So what next?
So next, I would like to do a colonoscopy with biopsy.
So let's see what the colonoscopy picture is. So here is the picture from the sigmoid colon, and this is viewed from a different angle. So would you like to describe the findings?
Sir, on the sigmoid colon, there is a large ulcer along with a whitish beige and thickened mucosal fold along with luminal narrowing with some oozing, mild oozing from the ulcer.
So let's see what the colonoscopist reported here. So they could only pass the scope till 20 centimeter, where they found a thickened fold with infiltrated and friable mucosa. There was a large deep ulcer with whitish base involving almost 30% of the circumference of the bowel. There was luminal narrowing, so they could not negotiate the scope beyond it, even with the help of a pediatric colonoscope. So they couldn't complete the colonoscopy.
The biopsies were taken, I suppose.
So they took biopsies and we have the biopsy result. This is the biopsy report. So there was nothing much. It was just some focal colitis. And again, we are nowhere now.
What would you like to do now? Since we are
Sir,
still
the
short.
biopsy was not suggestive of malignancy. It is non-conclusive, but there is a high suspicion of malignancy. I would like to do repeat sigmoidoscopy and biopsy.
So how frequent is negative biopsy, Dr. Rinkel? And what are the factors which affect the positivity rate of biopsy?
Sir, the factor which is the site of biopsy from when we are taking the biopsy. In the malignant cases, it is usually age spreading age where we yield a result most. When the biopsy was taken from the necrotic ulcer base, that time we can have a false negative biopsy. And when the lesion is infiltrating from the outside and it is caused just a mucosal thickening and ulcer, in that case, we can also have a false negative biopsy. And the number of biopsy also matters, as the higher number of biopsy when the malignancy is suspected would yield the more result.
So won't it be better if you go ahead with, because large mass, do an ultrasound and do an FNAC from that, rather than, because
Sir, if the yes, sir, if the second biopsy is also non-conclusive, then we'll go for a percutaneous biopsy, as the mass was very superficial. So we can access it by a percutaneous route.
So it is very important to remember that single negative biopsy, when we are suspecting malignancy, that we should not be happy with, because depending on technique, 10 to 30%, so positivity rate will be 70 to 90%, and 10 to 30% biopsy can be returned negative for malignancy. So if we are really suspecting, we should always go for second set of biopsy. And when we go for second set, we can use special techniques. One is there should be optimal number of pieces, so that will be 6+ pieces should be taken. Then we can take from the margin which Rinkel mentioned. So it is not the ulcer base which should be sampled, it is the ulcer margin which is more important to sample. And particularly if margin is everted, so that area should be sampled. And then in infiltrative type of carcinoma or malignancy, what we call well biopsy, that can be tried when there is suspicion of infiltrative type of carcinoma, either in the stomach or in the colon. So that should be considered. So here, did we go for repeat?
So in fact, the patient underwent a repeat colonoscopy and biopsy with all the precautions as suggested by Professor Sinha, but again, it was inconclusive.
okay.
So what to do next? Dr.
Sir, we'll go for the percutaneous biopsy
Biopsy or maybe an FNAC.
and the tumor marker also, sir.
Okay.
So let's see. I think I'll share with you the tumor markers first. So the CA was 8.43.
The CA is elevated. Rest of the tumor marker is normal.
So the patient underwent an FNAC, and this is the FNAC report. So there was a cluster of tumor cells with mild to moderate pleomorphism in a background of mucin. And there were some oval round tumor cells with coarse chromatin and inconspicuous nucleoli and moderate cytoplasm seen. So the pathologist gave a final impression of a mucinous adenocarcinoma.
So
it is very important to realize go back to the CT findings, that whenever there is mucin secreting carcinomas and that permeates through the wall for any reason, either local invasion of the tumor, the mucin tends to induce intense inflammatory reaction. What we are seeing in this patient. So this was the typical scenario where the mucinous cell have permeated the wall of the colon, gone outside, and there is local infiltration, local invasion, and because of mucin production, there is intense inflammatory reaction in the surrounding area. So interesting question coming up from the audience. Two questions. One is the role of diagnostic laparoscopy and maybe biopsy, or the second question is US guided biopsy.
Sir, for the laparoscopy, it is always for tissue diagnosis, always minimal invasive approach is selected. So if we can have a biopsy percutaneously for the very superficial mass, laparoscopy can be done if we have a doubt for the staging of the disease before going for curative surgery. In that case, it is better to have a diagnostic laparoscopy rather than just to have a tissue diagnosis. And regarding EUS, sir, the site seems to be arising from the ileocecal region. So however, the US scope diameter is much more than the pediatric colonoscope. So if the pediatric colonoscope was not possible, the US scope is also not possible beyond. And the true time biopsy from the sigmoid colon was non-conclusive.
Yeah.
So better than EUS, percutaneous biopsy would be a better option.
In fact, the role of EUS would be more for rectal carcinomas, where the staging is comparative to MRI and CT, rather than for the right-sided colonic. So I think one thing, what would you like to do a PET scan in this patient?
Sir, PET scan is not routinely recommended, but if a patient is being planned for the curative surgery in the advanced stage where the suspicious for the distance mets is high, in that case, we should go for the PET scan.
But is there any difference in protocol between the right-sided lesions and the left-sided lesions? Because what they say is in the left-sided lesions, they prefer to get a PET scan because they need to rule out the lung metastasis. Because what they say is on the left side of lesions, even in the absence of hepatic metastasis, you can find some lung metastasis. While on the right side of the lesions, even a CT involving the chest, if you see, is more than enough. So they go in for a PET scan, especially for the left-sided lesions prior to a surgery.
So, okay, what was done in this patient, Dr. Rinker? You can proceed on.
So this patient, in fact, sir, underwent a laparotomy, and the surgeons found out dilated small bowel loop and collapsed colon. They found a hard mass which was adherent to the retroperitoneum region, but it was arising from the ileocecal region, and it was infiltrating the bladder and the deep pelvis. That's why probably on colonoscopy the sigmoid was seen to be involved, and they did a diversion loop ileostomy for the patient. So these are the intraoperative findings. This is the hard mass which they found.
So what is the stage according to you?
Sir, for the based on CT, if preoperative TNM staging we need to decide, it will be a T4 because the tumor seems to infiltrating psoas muscle as well as ureter also. So it is almost T4B. For lymph node, we need to have a histopathology. At least 12 lymph node needs to be resected before commencing on the nodal stage. And at least on CT, there was no finding suggestive for the distant mets. So if the lymph node we could not be assessed, so the staging, it is difficult to say.
The possibility of stage 3 is there because we didn't find
Yes, sir, stage 3.
Right. Okay. Can we take up any questions from the audience? Or?
Audience poll. Here we have audience poll. I think.
Yeah.
We can go for.
We can't hear you, Anshuman.
So what fraction of patients with colorectal cancer present as an abdominal lump? So let's run a poll. The audience are invited to vote. Yogita ji, can you please run the poll? So the polling is in progress. So in fact, 15% say are in support of option A, 40% are in support of option B, another close to 40% are support of option C, and 9% in fact say it is option D. The correct answer, to the surprise of many, is almost 80% got it wrong, is 12%. So I think it's very rare for a colorectal cancer to present as a mass, because if you see, particularly if you talk of left-sided lesions, the stool is more solid there and the lumen is narrow. So they more often present as obstructive symptoms or bright red bleeding PR. Whereas in contrast, the right-sided lesions where the stool is more liquid and the lumen is more capacious, they are slow to present, and they often present as occult blood loss and anemia. So in fact, over 16 in this retrospective review of symptoms of over 1600 patients, only 12% do present as a mass. And in fact, series from our country, also from the TMH, also suggest the same. They haven't given the exact figures, but in their list of symptoms, CRC presenting as mass was not one of the major symptoms. So we'll run another question. So since GIST was initial one of the differentials, what fraction of patients with GIST present with an abdominal mass? So the audience are invited to vote on this. Yogita ji, can we run the polls again? So the poll has started. So let us share the results. Almost 1/3 feel it is less than 1%, and a quarter each feel it is 5%, 10%. So the correct answer is in fact less than 1%. It is very, very unusual for a GIST to present with the mass, because primarily since they are intramural, they might present with a rupture or a bleed more frequently. In fact, if you have a patient with GIST presenting as a mass, you can write down a case report. So from this case series published from MAMC in 2011, only till that date, 25 cases had been reported, including the 4 patients in the case series by Professor Kaza. So in fact, it's very rare. So we'll go up to the next question. So we can take the audience questions now.
Sinha, you are muted.
So not many questions coming as such. So just one question is, why not staging lap before laparotomy?
The patient had an obstruction, so they went ahead with divergent oleostomy. There was a little doubtful whether it was curatively resectable or not resectable. It was confirmed with intra-op that it was fixed to so many structures which cannot be reconstructed, like a bladder, ureter, or a pelvic wall. So anyway, this patient will need a divergent ileostomy.
So obviously this question answer will not come from literature or data. This is clinical judgment, and that can vary according to treating team, local ability of expertise, resources, and practices. So I think literature, we will not get support to any of this.
Maybe surgeons have got a good answer for that. Maybe.
And one question is role of chemotherapy. I think that is beyond the purview of this this forum at the moment. So we are basically clinical discussion. This is bedside type of thing. So
I think
that we will discuss.
I think Anshuman, you can take up the.
Sir, another interesting question has come up. What percentage of patients with intestinal TB present with a mass? Someone is asking. Dr. Wrinkle and Dr. Arup, would you like to take that up?
Sir, in the Indian series, about 10 to 20% of the intestinal tuberculosis has presented with a mass.
Okay. So in the we are nearing the close of the session, but before we end, I would like to sum up whatever Professor Sinha and Professor Mathura have taught us during the lecture, and take home learning points for all the residents, which are very important. So we'll just brush up the points. So the abdomen is divided into 9 regions with the use of 4 planes. This is a very basic fact, but then the residents are not expected to make any slips in this. So the 2 horizontal planes are: the upper horizontal plane is the subcostal plane, which lies almost at the L3 level. The lower horizontal plane is the transtubercular plane, and the 2 vertical planes are the right and left mid-clavicular plane and mid-inguinal plane. So this plane, vertical plane, runs between the mid-clavicular point and mid-inguinal point on the right side as well as the left side. So there is a reason why I've made the word regions and planes in bold. So at times we make occasionally slip of tongue is there, and we use the word quadrants, and there are some old school examiners who don't like this at all. So you should be cautious in what words you are using. And another thing is that you have to use the word planes. So these are not mid clavicular line or mid inguinal line or subcostal line. In fact, these are planes. So this is a very basic fact, but all residents should know this and not make these slips when dividing the abdomen. As we saw, almost 80% got the questions related to the regions and planes wrong. So coming to the organ of origin. So this is the exhaustive list of organs according to the region. A good way to think of it is when you try to think of the organs present in that particular region. For example, when you're talking about, say, the right hypochondriac region, you can think of all the organs lying within that, so that you can give a differential. The organ which lie are the liver, gallbladder, bile ducts, the hepatic flexure. But don't stop your list at that. It's always a good idea to look at the adjacent organs and see which adjacent regions or organs can invade into that regions. So for it would not be wrong to include ascending colon, the right suprarenal or right kidney into the differential. And similarly, there it would not be wrong to include head of pancreas, lower esophagus, and transverse colon lesions into the list. But again, don't stop at this. Think of the parietes as well. You should include, never miss the parietes. Include, for example, the lump could be epidermoid or a lipoma or a osteosarcoma rising of the rib. So in all, I would like to say that when you're thinking of a particular differential from particular region, think of the organs inside, think of the organs from the adjacent regions, and think of the parietes. And as a small tip, you can always, it's a good idea, you can place small bowel masses anywhere. So apart from it, you can place small bowel masses almost anywhere in your list of differential. Then once you have localized the lump, you need to make a differentiation between intraparietal and intra-abdominal lump. So with the help of leg raising and head raising, parietal masses do become more prominent, less mobile, and more painful to touch, as evidenced by the eponymous sign, the Fothergill sign, and the Carnett sign. And on percussion, they are usually dull, whereas an intra-abdominal can be either dull or resonant depending on what overlying structures are there. Once you have localized that the lump is intra-abdominal, you further need to differentiate whether it is intraperitoneal or retroperitoneal. So there are a number of factors, but remember that these are not infallible and gospel truths. There can be variations, so you don't need to just take one point and make your diagnosis based on it. You need to consider a number of factors while you try to localize the lump, because there can always be exceptions. So a retroperitoneal lump usually is poorly defined, does not move with respiration, and has less intrinsic mobility, whereas they are ballotable and bimanually palpable. And if you ask the patient to get into a knee elbow position, intraperitoneal masses tend to fall forward, whereas retroperitoneal usually do not. Retroperitoneal are usually resonant because there's sometimes small bowel might be overlying this, and intraperitoneal are usually dull. So again, I would like to emphasize these are not gospel truths. I have taken these from the S. Das, and you need to consider a number of factors together. Just based on one point, you cannot make a differentiation. Then you need to look at the clues towards the organ of origin in the history. Presence of jaundice would point towards a hepatopancreatobiliary source. Steatorrhea, new onset diabetes, and typical pancreatic pain point towards a pancreatic origin. If you are having symptoms of GI bleed or obstructive features, then you can think of a luminal etiology. If you are having urinary symptoms such as hematuria, pyuria, renal colic, think of the urinary system. And in cases of symptomatic with patient is symptomatic with palpitation, sweating, dizziness, new onset hypertension, you should always consider adrenal as a pathology. And then lastly, you should always consider benign versus malignant. Again, these are not infallible. These are slow clues that a benign growth is usually slowly growing with less marked weight loss and appetite loss. They're usually freely mobile, not associated with any regional nodes or distant mets, and they rarely do recur after excision as contrast to malignant swellings. So you need to take a number of points together. And definitely you don't want to invite the wrath of the examiners and miss out on these points while examining a lump in your examination. And always on inspection, you should mention the site, size, shape, color, surface and overlying skin edge, pulsation, peristalsis, movement with respiration and cuff impulse. On palpation, before you go on to confirm your inspection findings, you should always assess the temperature tenderness and then confirm the findings of the inspection and follow it up with testing for translucency, reducibility, compressibility, pulsatility. And at last, don't miss per rectal examination. So I would like to quote a favorite aphorism, which is often repeated by my teacher, Professor Uday Ghoshal. He says that if you don't put your finger into the rectum, you end up putting your foot in it. So never miss this per rectal examination. Then supraclavicular node examination is equally important. As Professor Sinha pointed out, that scrotum and testes need to be looked into detail to avoid any missing of testicular tumor. And you always want to look at the spine because iliopsoas abscess might be arising from a port spine. So you, in an abdominal examination, you don't want to be missing these 4 things. So I would like to ask Professor Sinha and Professor Mathur to take the proceedings forward.
Dr. Mathur, anything else we need to cover?
Can you stop sharing your screen?
Sir.
I think we can take up any questions if there are still queries regarding the, otherwise it's been comprehensively covered. We have had a good discussion on what is required in the history and the physical examination and the differential diagnosis. And over to Govind to finally conclude the session, since we are almost...
Thank you, Dr. Sinha and Dr. Mathur. But before we close, I have a couple of points to make as a take home. I want to take a question from Chandan. Dr. Chandan asked that in the exam or university exam, if there's absence of clinical sign or clinical symptom, is that against the diagnosis of a disease? I'm afraid it is not, because signs and symptoms are the reflection of the extent of disease or the duration of disease. If you see a patient longer in time, late in time, we have more signs and more symptoms. But also have learned myself over these many years that we are doctors of symptoms. Our medicine starts from symptoms. 3rd year, 4th year, undergrad, postgrad, and even during higher education, we talk about symptoms. You know that symptoms in chronic disease comes once we have a 60% of organs damaged. Symptoms don't appear in early part of disease, and therefore we always pick up a disease once symptoms are there. Means these are only advanced. We don't look at a disease once a disease is still in making. If you pick up a disease in making, you can reverse it. But if the disease is far advanced, we do palliative medicine. What we did today, again, is a palliative medicine, because we waited for lump to create, the symptom to get advanced. Patient didn't come to us because when the patient came to us, the disease is all treatable. So I think we should go away from this. Let's all try and educate our mind that we need to see the whole spectrum of disease. Not only the symptomatic phase, but look at the whole phase of disease. And liver is the best example. Liver pick up by just ALT rise. Any health test you find ALT is high, you start looking for hepatitis. You work off etiology and treat fatty liver disease, B virus, C virus, or whatever. But we don't have such marker for pancreas. We don't have marker for small intestine. We don't have marker for even brain. So we pick up a disease when they become symptomatic. So absence of symptom or absence of sign does not mean absence of disease. We need to see the patient in total. And we are at the highest level of our training. We are super specialists. So we need to be more open in our thinking. Second point, I want to make that if you look at the lump is bigger, but there are no signs. The symptoms are much less compared to size of a lump. Then you think the lump is growing in a potential space. And one of Bilal made this point that if, for example, in mesentery or in retroperitoneum, there's no function there. It's all lump, and it can occupy a lot of space, and they produce symptom by replacing the normal organs. They don't have a symptom of their own except for pain. Pain is a mechanical symptom. Therefore, and that's also an example that a 1 centimeter tumor of ampulla can become symptomatic and lead to jaundice. 1 centimeter tumor or 1 centimeter tumor of a cholangiocarcinoma becomes symptomatic because of jaundice, because size is too small. But 1 centimeter tumor of a stomach will not be even seen. Will not even on endoscopy you're going to miss it. Therefore, it all depends upon that where lump is there and how much of organ compromise will occur because of particular lump. So we need to keep these points in our mind. Second, they said that he rightly said that why carcinoma colon do not have lump palpable. Because by the time lump is palpable, the patient will be symptomatic with intestinal pain or symptoms. Therefore, only few of them have lump palpable. Lump means what? Lump of mesentery will be palpable because there's no organ loss, no loss of function. Whereas in intestine, there's a loss of function. Obstruction becomes a loss of function. Therefore, lump are not palpable, mostly in pancreatic tumors or in tuberculosis or also in colorectal cancer. Only few have lump palpable, but this is far advanced. I think with this, I want to thank. Yes, yes, please.
To convey to DM residents, if you have seen what Anshuman has presented and the entire discussion, the carry home is that 2 books, that is, he quoted S. Das and Hutchinson, which is a must for all DM residents to read. So all his take-home messages and all the answers were there. So please read these 2 books for your bedsides.
Absolutely. And looking at S. Das, lump abdomen, probably best described in S. Das. I think get your book back. It might not open the book during MD time, but now there's high time to open this book for at least for lump examination. The chapter is wonderfully written in that book. I think with this we thank Dr. Amit Mathur. I think he did wonderful job today and taking a very important question. Thank you, Dr. Saroj Sinha, for again taking up the very important clinical points in lump abdomen. Anshuman, thank you very much. You have been absolutely fantastic bringing those important poll questions, and through that question imparted education into all of us. Thank you, Arup, and thank you, Wrinkle, for a wonderful case discussion. I think you did a wonderful job and brought the point to the important points all of us to learn. And as I said, this is not a teacher-student kind of bedside. This is a kind of panel discussion where we discuss with open mind with all the resident participants. So with this, we close today's program, and thank you very much, everyone. We will join back next Sunday again with one more case discussion that will be on recurrent jaundice and how do you approach recurrent jaundice. We'll have a galaxy of faculty, and we'll have case presentation from one of the institution. With that, happy Teachers Day to all of you, and have a great day ahead. Enjoy your Sunday, and we can log off. Thank you, Yogita. Thank you, Manish and Dinesh, for wonderful coordination of this program.
Thank you.
Okay, bye-bye. Bye-bye.
Thank you, everybody.
Thank you.
Thank you.